Hello everyone, this is Sami Said from CTSNet, and we're here at the annual meeting of the EACT in Vienna. And I'm honored today to have Dr. Hani Najm, who doesn't need an introduction. He's the chair of the pediatric and congenital heart surgery at the Cleveland Clinic. Hello, Dr. Najm.
Pleased to meet you. Thank you so much.
Thank you. We've selected this topic really because of how important it is for our congenital community. And Dr. Najm has an important presentation tomorrow about the ventricular switch operation. And we're here to discuss a few of the perils about this procedure. So can you explain to us what's the concept of the ventricular switch?
Yeah, so what happened is we were faced with some patients who are either failing single ventricle pathway, or they're parked in a situation where the left ventricle cannot be adopted as the systemic ventricle. So our surgical community has resolved into using both ventricles as a single ventricle and converting them into a single ventricle pathway. The problem with that model, as we all know, we've been doing Fontans for the last 50 years or so, they inevitably fail. And when they fail in multi-organs. They will have liver cirrhosis, they will have kidney dysfunction, they'd have protein-losing enteropathies and PLEs, all this, the plastic bronchitis, all this multi-organ because of the venous congestion of the Fontan, which is inherent to the single ventricle. So now you've got a ventricle, you've got a heart that has two ventricles that has been used as a two ventricle circulation because of what's called an unseptatable heart. As in, you cannot route the left ventricle to the systemic circulation, then you just resolve to using both ventricles as one ventricle. So here we came with this concept, which is a different, open your horizon to the ability to convert these patients into a biventricular circulation, using the right ventricle as the systemic ventricle and the left ventricle to become the subpulmonary ventricle. And the reason for this, despite that we know that these are not the ideal conditions, but they are better than a single ventricle pathway. And we know and we have some ideas about how the right ventricle behaves in the systemic circulation. One of the commonest example is the congenitally corrected transposition, whether they have had repair or not, whether it's an anatomical or a physiological repair. The other example that we have is the patients who've had a mustard procedure or an atrial switch procedure for transposition of greater arteries. Still, the right ventricle is the systemic ventricle. So what happened to those patients? We've seen a lot of publications that looks like the right ventricle will function very well for 20, 30 years in the systemic circulation. And then if it fails, it does fail, but when it fails in heart failure pathway. So it doesn't fail in a way that the single ventricle pathway fails, which is multi-organs, liver cirrhosis, and all that stuff that all of us know about this. So, and not only this, once you have right ventricular failure, yes, you can actually do the heart failure therapy for them, whether it's the medication, whether it's the assist devices or transplantation, but it's a single organ failure, which is the heart. And that's why we've adopted this and we've introduced the ventricular switch concept. And I call it a concept rather than an actual operation, because it's a series of an operation which will lead you to a two ventricle circulation using the right ventricle for the systemic and the left ventricle into the subpulmonary ventricle. Now, there are two ways or multiple ways of getting to that. Either you choose to do this right when the baby is born, you say, well, this is one of those, especially, by the way, the heterotaxy patients. The left ventricle is so far and it's L malpose, it's anterior, it's very far, and it cannot be relocated or connected. The other pathology that is well known also, a double outer right ventricle with a remote VSD. So two great vessels come out of the right ventricle, the VSD is far and it's not routable to the aorta, then these patients are routed into a single ventricle. And there's the crisscross hearts with upstairs and downstairs or superior and inferior ventricles. All these complex lesions that have been saying like, okay, fine, just leave them into a. The other added value also, even if you have a moderately hypoplastic left ventricle, so even in a standard Jones complex, where you have a left ventricle that is not adequate for a systemic support, why completely discard that left ventricle and use the whole ventricle as a systemic ventricle, as a single ventricle? So what you can do is you could do exactly the same thing. Fine, that left ventricle is not suitable for a full cardiac output. Use it for a half cardiac output, which means that you could do a bidirectional gland. Then you need to do the arterial switch because the coronaries are coming out of and you do the hemimustard. And all of a sudden now you've got a left ventricle that supplies the IVC, goes to the good thing about this, the whole concept of the ventricular switch is to have a low atrial pressure. That is the whole concept. And you can only have a low atrial pressure with a ventricle and a valve, which is, so when you have a low IVC pressure, that's what you get. So this is the overall concept and the different types of cases that can be suitable for a ventricular switch procedure.
And you've done a good number of these cases now. I believe my last information was in the AATS, you presented about 17 cases. Did you do any more?
So we did 17 cases. That was actually in the last World Congress that we presented just a month ago. And they keep coming, and they're in different stages. So now we've converted some of the Fontans back into a biventricular circulation. And the only thing, talking about pearls and which are the best patients for doing this, you really don't want to do them when they are really at the end of their Fontan failure, because this is a bigger operation. It's always going to be the fourth operation because the patient had a Fontan at least. So there'll be the fourth operation. Second thing is you really want the liver function to be okay, the kidney function to be okay. You don't want them at the end of their Fontan failure, so you want them a little earlier. The other thing that we have learned also from doing this operation is that because these two ventricles have been pumping in the systemic circulation, when you convert the left ventricle to become the subpulmonary ventricle, it takes time for it to involute to become a low pressure. So it still has a higher end diastolic pressure. So you need to treat them for some time until that ventricle gets used to regress and then gives you the lower venous pressure. So that's why we believe that if you were to adopt this, take this earlier, so you subject that ventricle into a lower pressure earlier. And it doesn't have to be done. It's also a lot of surgery to do them because you got to divert all the systemic and venous. And each one of them is a little different than the other. So you have to actually, that's why we use 3D printing to see where the entrance of the systemic veins, where the entrance of the pulmonary veins, because a lot of them are with the heterotax, they have complex connection, I would say. And a lot of them had also repair of total anomalous pulmonary venous arterial previously. So it depends where these the pulmonary veins have been plugged into the atrium. And then you start looking at this and then deciding this is the best way, this is my route. And that's why I like to have them in my office, on my desk. I look at the 3D print multiple times, and there's different iterations of how I could look at this. Sometimes I would translocate one vein to the other. Sometimes we do all these little different, but the actual technical part of it, all the congenital surgeons have done, whether it's a bidirectional.
Just in pieces.
It's in pieces, exactly. It's putting them together, putting the puzzle together. And that's why you need to do this 3D printing. And then you say, well, I'm going to divert these systemic veins, and these are the pulmonary veins. And then obviously, if you have a common valve, then you have to septate the common valve, which is not uncommon. It's, as you know, common with the heterotaxy. So all these things have to be factored into the equation as you do the septation for these ventricles.
Great. And who what's the youngest patient that you've done so far?
So the youngest patient was 3 months, and he is that kid came to us, was ventilated from birth and from another institute, and he was 3 months, and he had a double auto right ventricle with a remote VSD. He was in heart failure and blue, as typically you'd see with the bad streaming and because of the VSD. So, and he was on intubated, and that's why I thought, let's just close his VSD, do atrial switch, and do an LV to PA conduit. And he has done well since then. Actually, he's the youngest patient. The oldest patient is 46 years of age. And that guy really gave us a lot of trouble because he was failing Fontan and his liver. And that's what I was saying, doing him late. You want them before that. But interestingly, and I have a screenshot of his hemodynamics before and after. He comes in to the operating room with a CVP of 40, 41, and he leaves the operating room with a CVP of 18, a CVP of 14 and an LAP of 18, which is very fascinating because he had these two large ventricles. Interestingly, that both ventricles would pump one cardiac output. Once you septate and you route them, each ventricle will pump a full cardiac output, one to the lung and the other one is to the systemic. So it's a proof of concept that you can actually do this. And they do have lower atrial pressures.
And I think you mentioned that already, but my question was, how do you prepare these patients and how do you select them?
So the decision making, our default, as everyone would go, can this left ventricle become the systemic ventricle? Sometimes it's not easy, especially in borderline plastic left ventricle. You want to promote it, you want to close the atrial septum. It depends on your belief on that. Could that ventricle become the systemic ventricle or not? Whether it's small or whether it's unroutable because it's too far and it's unseptatable. So if it's not, then right from the birth, start planning for that. So you plan your surgeries in a way that you could do, because you don't want to do everything, and you can't do this really at the newborn period, because a lot of it may require a bidirectional glen. So you can do a bidirectional glen and sit on the patient, make sure that they're fine, and so that at least you reach to a stable condition, and then revisit the issue at around, I would say around 2 years would be a good size to do the other conversions, between 1 or 2 years. We're accumulating more. One thing we've also learned, and I think it is important to mention, is that sometimes when you don't have early AV valve regurgitation, I started putting in a prophylactic annuloplasty, because some of these valves, because they are okay before they are septated. Once the septum shifts, because now you've got a lower pressure and a higher pressure ventricle, the systemic AV valve may start leaking, and that's why I don't want it to dilate, and I do this annuloplasty. It's just like a strip of bovine pericardium with a few horizontal matrix. Nothing magic about it, but you just do it there just to restrict the annulus so it doesn't dilate too much, because the septum will shift, because you will have lower and higher pressure system, as we know with the CCTGA.
And you mentioned already, so you do 3D printing for all these cases prior to any final decision?
We do 3D printing physical, and you can do the virtual also, which is the virtual reality, and you could wear your goggles and see them. Now we're doing more of this virtual also, but I still like the 3D printed heart itself.
In your hand.
It's like, and if it's tiny, what I tell them is, actually, if it's a small heart and it's too small, I would say, well, can you print them twice the size? They could do that for you. So now they just make it bigger for you, so you can actually plan for your next operation when the kid grows up.
And I guess that's a fascinating concept, hopefully better for the patients, because we all know that the Fontan operation is not ideal, but it's easier compared to multiple serious operation, and maybe that's where the hesitation comes. So it comes a controversial question when a patient who is a very good candidate for a Fontan versus a ventricular switch, how to make that hard decision.
So I can tell you our index case. the cardiologist came to me and said, Hani, can you please do something for this 9 years old kid who's very blue and he's on a wheelchair. He's debilitated. And this was the first one, and I looked at it, and he was heterotaxy. He had a previous arch repair. I don't want to go through the details, but basically he had his pulmonary artery and aorta coming out of the same ventricle, although he had a bystanded left ventricle was doing nothing. So I said, okay, the first thing, and I didn't even think about ventricular switch at that time because that was the index case. And then basically I went in and I septated his atrium. I didn't even septate his VSD because he had previous MAPCAS reconstruction. He had already restriction of flow and the pulmonary circulation. So I just needed to do an LV to PA conduit. Then all of a sudden, this kid was literally playing basketball, shooting hoops a year or 6 months later. And it's on the media. So this concept was born because of necessity. And I can tell you, you will see these patients in your practice. There's no way, it's not a choice. You will have these patients coming and they are going to be in your lab. And it's upon you whether you want to actually do something about it or let the patient literally die. But now we're bringing this patient a little more elective situation. So these are like salvage conditions where you have a patient who is really not parked in an area that you can't do anything about it. But then now you can actually do it earlier. So you do not choose to go the Glenn Fontan circuit and you say, well, listen, we know where they're going to go. Especially the heterotaxy and common AV valve. We know where they're going to go. They're going to leak. They're going to have severe AV valve regurgitation, and they're going to be too sick to do any surgery for them. All these, we know them. So you say, well, listen. And you know what? We know that AVSD, the common valve, the best stabilization for a common valve is septation. We do this all the time, and that's why they're not. But if you just leave it as it is, it's going to dilate, it's going to leak. We know this. It's inevitable. So the concept is there. So now with all this information coming in, we got to have to start thinking. I'm not saying that there will be like hundreds in every practice, but I would say that you will have this opportunity to save some of these patients who are going to be better candidate for this rather than the single ventricle.
Excellent. And how do you, I guess your cardiology team, did you get them all on the same page?
I tell you, it was not easy, especially the first few. The first few, obviously, when it was presented, it was salvage, literally, because we needed to do something. There's no other option or letting them die, the kids. And sometimes we say, well, okay, maybe it's better, but we shouldn't be like this. I think we should be pushing the science. We should be pushing innovation, because every time we push innovation, something else comes out of it, some more understanding of the pathophysiology, more understanding how can we do this. So we started doing this. They actually came to me with a solution, requesting a solution. But then afterwards, we started adapt. The concept of a ventricular switch when it's introduced is like with people, what are you talking about? You're taking the ventricle. So, and that's where it becomes just an understanding of the concept. Now they are coming to me. They're telling me, we've got this guy who has been 17 years in the Fontan, and he's got another ventricle in their Fontan clinic. What do you think? And then we're starting to look at this because they start having, I wonder whether we should start even biopsying livers of Fontans, because as you know, we've all done Fontan transplants, combined heart liver. They're not the easiest. They're not the small, and their outcome is not the greatest. And you cannot reverse Fontan physiology with an assist device either. So it's not like you put an assist device and everything comes back to normal, and then you can actually transplant. So all these complications that comes in with the Fontan patient, if we can have a solution that avoids this, would be the best thing.
Isn't it amazing that most of these novel solutions just comes only from disparate situations?
Absolutely. As the say goes, necessity is the mother of invention.
So thank you so much, and I hope continuing success and continue to follow up all the news of the ventricular switch, or do you like to call it reverse double switch?
No. Reverse double switch does not give it a fair and description because it's not, first of all, to understand a double switch, people are starting to get around their head, and it doesn't give it the right description. The ventricular switch, and I'm glad you bring this up, the ventricular switch applies to a much bigger group of patients. Yeah. So the reverse double switch applies specifically to patients with Schoen's complex, moderately hypoplastic left ventricle. And that's why I don't call the atrial switch an atrial switch, I call it an atrial conversion, because they do not comply with the standard two anatomical or technical atrial switch, which is the mustard or the Senning procedure. Each one of them will be a little different because the pulmonary vein is in a different position, the SVC is different, and all this is dextrocardia. There are bilateral SVCs, there's a hepatic and an IVC. This is what we usually see. It's not an atrial switch anymore. It's an atrial conversion, and that's why I think calling it a ventricular switch, it encompasses all these: the heterotaxy, the hypoplastic left hearts, and all the other.
It's the broader name, and I think it carries also the concept in the name.
Exactly.
And people get the point.
Immediately get the point. Exactly. Now you're actually adopting the right ventricle as a systemic ventricle.
Thank you so much for this wonderful interview. Always nice to meet you. And we'll continue to hear the updates and follow up on these patients.
Absolutely. Thank you for this opportunity.